Good evening and welcome to Over the Counter, a half-hour show that focuses on health. My name is Monique Hammond, I'm a pharmacist, and tonight our topic will be Alzheimer's disease, with particular attention to research. And my very special guest for tonight is Dr. William Fry, who is a PhD and a neuroscientist of international acclaim. Dr. Fry has appeared on such shows as Good Morning America and Inside Edition and so many more, and tonight we are so very fortunate to have him here with us, and he will talk to us about Alzheimer's disease because he is also the Director for Research at the Alzheimer's Research and Treatment Center at the St. Paul Ramsey Medical Center. So would you please welcome Dr. William Fry. Well, good evening, Dr. Fry, and welcome to the show.
Thanks, Monique.
And thanks for talking to us tonight about Alzheimer's disease and research. Dr. Fry, whenever we talk about Alzheimer's disease, we say that it is a form of dementia. Now, in the words of a neuroscientist, what is a dementia?
Well, dementia is a general term, kind of like the term senility. It really is just a term that describes a variety of different diseases that all have fairly similar symptoms. And those symptoms would be memory loss, confusion, disorientation, personality change, that type of thing. So it's not a very specific term, but just a general term to say that a person has some kind of organic illness that is resulting in memory loss, confusion, disorientation.
So if we say that Alzheimer's is one form of dementia, there must be many of them out there. How does Alzheimer's actually differ in the symptoms or in distinguishing it from other dementias?
Well, there are some differences in the symptoms of Alzheimer's disease than you would have with other types of dementia, but unfortunately those differences are not large enough or pronounced enough to allow a physician to really distinguish Alzheimer's disease from most other dementing illnesses. But I'll give you an example. One type of dementia is dementia due to small strokes or infarcts. We call it multi-infarct dementia, meaning many small strokes. Occasionally, this type of dementia can be distinguished by symptoms from Alzheimer's disease, because when a person has a small stroke that is affecting their memory, the change in their memory may be very sudden. And so one day they may be basically fine, and the next day they may have a memory problem. Alzheimer's disease tends to be a more gradual, have a more gradual onset and more insidious onset. And so if a person is doing fine and all of a sudden has a problem with their memory, then the physician would start to think, well, gee, maybe this isn't Alzheimer's, maybe it's multi-infarct dementia. So there are some symptomatic differences between the different dementing illnesses, but they're not good enough to really distinguish them. We've seen many patients who physicians felt had Alzheimer's disease who turned out to have some other dementing illness, whether it was multi-infarct dementia or perhaps Pick's disease or some type of Parkinson's dementia or there are many other types of dementing illnesses.
Now, when we're talking about Alzheimer's disease, now we are always getting very spooked out when it comes to the younger groups. Now, we do get it more though as we get older, correct?
Yes, the risk of getting Alzheimer's increases almost logarithmically with age. So very few people get the disease in their 40s, a few, but very few. And then in the 50s you see a few more. Most people, however, who get Alzheimer's disease don't get it until they're in their 60s, and then in the 70s you see a lot more, in the 80s a lot more in terms of the percent of the population. If you look at people who are, say, 65 and older, you're looking at maybe 16 or 17% of the population. But if you look at people who are 85 and older, you're looking at about half the population.
Okay.
Yeah. So it is something, the older you are, the greater your risk for getting this illness.
Okay. Now, what about sexes? Are women more affected than men or vice versa? Or?
Women are slightly more affected than men, but it's not a big difference. It might be 46% of the people who get it are men and 54% are women. It's not a large difference.
Do we have racial differences?
Well, I am not really aware of ethnic differences or racial differences that have been, really verified. There are some reports about differences in Africa or in China or what have you from the United States, but it's very difficult because the method of diagnosis is not really the same, and I'm not really convinced that there are real ethnic and racial differences in terms of susceptibility to this disease.
Now, Dr. Fry, when we talk about Alzheimer's disease, we all know about the forgetfulness and the confusion that those people are, characteristically coming down with. Now, when is forgetfulness? We all forget. We
Yes.
forget our telephone number at home, we forget our keys, we forget where we put things. When is forgetfulness worrisome? When should we take action?
Well, usually when the time to take action is when it starts to really interfere with your functioning. People, as you say, forget many things. I've been driving down the highway and not for a few moments, maybe not even remembered, well, where was it I was going?
Yes.
And then I have to sort of think back. And as you say, people forget their car keys, and appointments occasionally. But generally with a person who has Alzheimer's disease, they're not only forgetting things like that, but they're also forgetting very significant things. For example, they may cook breakfast and then a few minutes later forget that they cooked breakfast, forget to serve the breakfast, not remember having cooked it. Sometimes they'll go back and make another egg or a third egg, kind of repeat this process because they simply don't remember. People with Alzheimer's usually have the most trouble with short-term memory rather than long-term memory. So they may remember things that happened when they were very young, quite clearly remember those things, but they may not be able to remember things that happened just the day before, or even maybe a few hours before. So I think when the memory problems become noticeable to others or to the individual themselves, and they start to really interfere with functioning, when people get lost, can't find their way home, or have very significant changes in their personality, their mood, become very suspicious and sort of paranoid or what have you. Or you can have sometimes symptoms that are different. Some people are affected more with visual spatial perception problems. But anything that becomes really noticeable to the individual, that they wonder about it or their friends or relatives wonder about it or interferes with their functioning, should be a clue that it's time to go to a neurologist or someone who's knowledgeable about these disorders and have a diagnostic workup.
Yeah, somebody was saying, if you forget your keys, that's not so important than if you forget what they are for.
Right, that's true.
That kind of a thing.
Yes.
Dr. Fry, now, is Alzheimer's disease genetic?
Probably in many cases there is an inherited risk for the disease. So yes, it is probably genetic in many cases. We don't really know what percentage of the cases are due to some genetic abnormality or that people have gotten as a result of some increased risk because of some genetic abnormality. It was thought for some time that genetic or hereditary abnormalities accounted for only maybe about 10 or 15% of the cases. However, recently, research done by Alan Rose's group would suggest that a particular gene called ApoE, which stands for apolipoprotein E, this is a certain lipid-carrying protein, that the gene coding for this protein may be altered in a lot of people who have Alzheimer's disease, putting them at significantly increased risk, where their risk may be, say, 8 times that of an individual who doesn't have that genetic abnormality. So I think that it's looking more and more like a genetic abnormality is involved in probably the majority of cases. That doesn't mean, though, that if your genes are fine that you won't get the disease. It also doesn't mean that if you have this genetic abnormality that you'll necessarily get Alzheimer's disease either. Okay. But I think there is a significant genetic component.
What other causes are there for it?
Nobody really knows. There are, other than family history and genetics, there is some evidence that people who are knocked unconscious may be at a slightly higher risk for this illness than people who are not knocked unconscious. But this is only a very minor risk factor. Most people who are knocked unconscious don't get Alzheimer's. Most people who have Alzheimer's were probably never knocked unconscious. But still, if you actually compare those groups that have Alzheimer's with those that don't, you'll find a slightly higher incidence of that. So that could be a minor risk factor. People suspect that there may be things in the environment that may help to trigger Alzheimer's disease, but no one has really identified anything yet. Whether there's some virus or whether there's some toxin in the environment or something that gets into the brain and causes or triggers the process, particularly in people who are genetically at risk, for example. We don't really know.
Yeah, we have been talking about maybe an autoimmune reason, hadn't we, where the body destroys itself, kind of?
Well, there is evidence that there is an immune or inflammatory response as part of Alzheimer's disease. It does involve some kind of inflammatory process in the brain. We have done research in this area, other people have as well. We know that there are certain chemicals that increase an immune response called cytokines, and these substances do seem to be increased in Alzheimer's disease. Exactly what role they're playing and how they may be triggering or helping to induce damage to the nerve cells and degeneration of the nerve cells, we're not really sure. There are a lot of theories about it, but we're not really sure.
Okay, let's cut right through the fat and get to aluminum.
Okay.
How about the aluminum connection? Everybody says, oh, you can't drink out of an aluminum can, you can't have aluminum cookware, you can't use any antiperspirants anymore. Now it gets dangerous because this all causes Alzheimer's disease. Right?
Well, that's a very good question. Aluminum is a very widespread element. There's aluminum in the air and the water and the dirt. As you mentioned, it's in antiperspirants. It's certainly in drugs like Maalox, which is magnesium and aluminum oxide, and it's in a variety of antiperspirants, a variety of things. So far, I have not seen any evidence that would convince me that aluminum causes Alzheimer's disease. There is evidence that aluminum can accumulate in the brain in Alzheimer's patients. But we don't really know whether that isn't simply due to the fact that as the brain becomes damaged, many things that should not be accumulating there may accumulate once the tissue is damaged and you don't have the normal processes for keeping things out of the brain, etc. I haven't really seen anything to suggest that aluminum has some causative role in Alzheimer's disease. There are a few researchers who I think believe fairly strongly that it does. Most researchers do not agree with that, is my assessment. But Alzheimer's disease is a very complicated disease, and until we know all of the causes, it's very hard to rule anything out. Personally, I would not be concerned about aluminum foil or eating off of aluminum, using aluminum cookware. These are not things that would concern me, or taking Maalox. I would be concerned about inhaling aluminum, though, for example, in antiperspirant sprays. And the reason I say that is that we know that Alzheimer's patients tend to lose their sense of smell, and the area of the brain involved in smell is connected to the area involved with memory. And the area involved in smell, of course, sends nerve projections down into the mucosa of the nose, the olfactory area of the nose, in order to sense odors. And certain substances can be taken up along these olfactory nerves into the brain. And that may be a good thing for us because eventually that may be the way we will end up delivering drugs to treat Alzheimer's disease, delivering them to the areas that are in fact involved in the brain by administering them as nose drops and having them taken directly into the brain along the olfactory nerves. But it also could be involved perhaps in the uptake of harmful substances from the environment that might, cause brain damage or what have you. So I guess my only concern with environmental things would be really things that you might inhale. And so I personally would avoid antiperspirant sprays. On the other hand, the studies that have been done really are not very convincing that antiperspirant sprays cause Alzheimer's disease.
Right.
People have looked at that. The data is not real strong. So
it would be considered like maybe a risk factor or something like that, something
to avoid. It might be, but it has not even been shown to be that yet. So I really don't think the case for aluminum is very good, frankly.
Okay. What exactly happens in the brain of an Alzheimer? When you look at your microscope, what do you see? What has changed?
Well, you can see certain things in the brain of an Alzheimer's patient which you would not see in the brains of people who have other types of dementia. And in fact, that is one reason why when a neurologist would do a neurologic exam to determine whether a person might have Alzheimer's or have some other illness, they can never really say, having done the exam, that this person has Alzheimer's disease. They will do the diagnostic workup and they will be looking for treatable disorders, things like a vitamin B12 deficiency that can cause similar symptoms, a decrease in thyroid hormone, They might look for small strokes by doing brain scans and other kinds of things. When they come to the end of that, they might say, well, this individual probably has Alzheimer's disease, but they can't be sure because they can't really see the brain directly. If an autopsy is done, however, and the brain is examined after death, we do see some brain changes that are very characteristic for this disease. One thing we see is that the nerve cells are degenerating and dying. Inside the nerve cells, we see accumulations of abnormal proteins that are called neurofibrillary tangles. They get this name because they're in nerve cells. That's the neuro. They're fibrous, fibrillary, and they are tangled or twisted around each other. These neurofibrillary tangles, sometimes also called paired helical filaments, are composed of basically what looks like two proteins twisted around each other in a helix. We know a little bit about the proteins that make up this neurofibrillary tangle. They are probably composed of some proteins that started out being normal but became abnormally phosphorylated or altered by an enzymatic reaction in the brain. We're not exactly sure what triggers that or regulates that, but once these abnormal protein tangles accumulate in the nerve cells, they undoubtedly interfere with the ability of these cells to send and receive signals, and then that interferes with the ability to remember and do other kinds of things. In addition to this, we also see outside of the cells accumulations of another abnormal protein called amyloid. And this amyloid has been found to be toxic to nerve cells. That is, it can injure or kill nerve cells. It's a complex protein which we don't know as much about as we would like to. It may in some doses and in some situations even be able to protect nerve cells, but in Alzheimer's disease it looks as though it is causing a lot of damage. So by finding these amyloid accumulations, which we call neuritic plaques or senile plaques, and by finding these Alzheimer's tangles, we can say, gee, this person has Alzheimer's disease. You would not see that kind of pathology at the cellular level if you looked at the brain of a person who had had many small strokes, or if you looked at the brain of a person who had Parkinson's disease or Pick's disease or some other kind of dementing illness.
Now, when I think of the brain as being like a big electrical box, like a fuse box almost, and you think that there are fibers that are tangled and you have deposits of plaques, wouldn't one think one would get more specific symptoms for all of this than just the sort of the vague confusion, forgetfulness, that kind of stuff? Wouldn't you think those people would start seizing at some point in time, have seizures, have troubles with vision, anything?
In fact, Alzheimer's patients do have seizures, usually later in the course of the disease. That's not uncommon. Some Alzheimer's patients do have problems with vision, not because there's anything wrong with the eye or the connection to the brain, but rather because the areas of the cortex that are involved in integrating the visual information, the associative cortex we call it, in the occipital lobe that's involved in processing this visual information can be damaged by these tangles and plaques. And so we do see perhaps about 20% of Alzheimer's patients who present with a visual spatial perception problem. Maybe they simply can no longer play the piano. Their memory might still be quite good in the early stages of the disease. Or we will see people who have a lot of difficulty dressing themselves and doing other kinds of things like that. The areas of the brain that are affected earliest in the disease will determine in large part what the symptoms that the disease presents with, which symptoms the disease will present with. Almost invariably, though, as the disease progresses, a lot of other areas become involved, and then the symptoms do become quite generalized, and you see a lot of different symptoms.
Now, are the seizures that an Alzheimer's patient gets when they look at an EEG, are those different or have different focal points from where they're coming from than a person, for instance, who has epilepsy or even old age kind of things?
That's a good question, and I'm not going to try to answer that because I don't know the answer to that.
Okay.
I'm sure that people have looked at that, but that's really out of my area enough to where I would be afraid to answer that question.
Okay.
It's a good question. I'll have to look that up.
Okay, then we'll pass on that one. Then I was also wondering about the diagnosis of Alzheimer's. Now that really seems to be a real problem, and you kind of alluded already to it, that you have to look at a lot of factors. How do we diagnose it then in the end? For instance, scans, are there tests that we can use?
Well, there are some tests we can use. The first thing I think when a patient presents to the physician, and I should point out that I am not a physician but a medical researcher, but I can pass on my experience with this and what I've heard from physicians that I work with, is simply that you want to first determine what kind of problem does this person have. Are they having delusions? Are they having problems with their memory? Are they having language problems? Are they having visual spatial problems? If they are they having problems finding words, or are they inappropriately picking the wrong words? You know, is it short-term memory, long-term memory? All of these kind of questions are very important and will help direct the physician towards a proper diagnosis, and also towards knowing what type of test is most likely to be helpful with the particular patient. In general, a lot of these questions are answered by neuropsychometric testing and by where patients are given tests to assess their memory and other kinds of functional things, and by just the basic neurologic exam that the neurologist or other physician might conduct. Once the symptoms have been determined, if it looks, and of course they will assess the drugs that the patient is on, because sometimes in the elderly you may have some iatrogenic illness where the patient is on so many medications they could be having some bad effect from the medication. They would want to, of course, rule that out. Of course, they'll take a complete history of the patient to find out what their health has been so far. For example, if a person has a history of diabetes and hypertension or high blood pressure, then they would be at very high risk for stroke. And that type of individual may be more likely to have a vascular dementia or a dementia due to many small strokes than perhaps Alzheimer's disease. So all of this kind of information is collected and analyzed by the physician. The physician then would do certain tests. They would want to do some blood tests, and this would be to eliminate the possibility that the individual simply is deficient in thyroid hormone, that their thyroid gland with aging has not just all of a sudden stopped putting out enough thyroid hormone. If that's the case, you can get symptoms very similar to Alzheimer's, but we know it's treatable. The individual can take a drug, Synthroid, or a synthetic thyroid hormone. They'll also want to check the blood for vitamin B12 levels, make sure that the person isn't suffering a B12 deficiency. If they are, they will get B12 shots. I know of individuals personally who were very worried about their memory. I dealt with a particular individual in some business that I was dealing with outside of work, and she kept missing the appointments. And I asked her, I said, gee, how come you keep forgetting to show up at the appointment? And she said, you know, I just can't seem to remember anything. And she mentioned also that she was very tired. So when she said those things, I said, well, have you seen your doctor? And she said, no, she hadn't. Or she had seen her doctor. Yeah, she said she had seen her doctor, but he didn't really say much about it. And I said, well, I think you better go back and talk to him again, and you might want to have your B12 tested, because one of the symptoms of B12 deficiency can also be fatigue with anemia and all of that. And sure enough, it turned out she was deficient in B12. With B12 shots, she recovered and was doing fine. But without getting treated for that, your memory will deteriorate really substantially. So anyway, these are kinds of things. Then they would want to look at brain scans to find out whether or not this individual may have had a stroke that is visible on a brain scan. This would be either a CAT scan, a CT scan, or an MRI, magnetic resonance imaging scan. And also, of course, there is the odd case of a brain tumor or something else that might show up on a scan. And there are other kinds of tests too, but those would be the major types of tests, I think, that would be done.
So basically, how we are diagnosing it then is by finding out what it is not.
Yes, it's a diagnosis of exclusion. And having excluded all the other likely illnesses that we can diagnose, the physician comes down to saying, well, this is probably Alzheimer's, but he cannot be sure, because there are still a number of brain degenerative diseases that cause the same symptoms as Alzheimer's, which, just like Alzheimer's, we have no definite test for yet.
Right. Dr. Fry, there was another question that I had, and that was, if we have people that are so difficult to diagnose, you kind of talked a little bit about it before, how many of them do we roughly know that are misdiagnosed?
Well, I think that the percent that are misdiagnosed is decreasing. As more and more physicians become educated about Alzheimer's disease, as more and more papers are published by our group and other groups who have studied Alzheimer's patients, the medical community in general, I think, is getting better at diagnosing Alzheimer's disease correctly. At one time, I would say there were probably 25 to 30% of the patients that were misdiagnosed. That is, patients who were told they had Alzheimer's but did not have Alzheimer's. Right. Okay. Today, I think that it's probably closer to about 15% of patients who are told they have Alzheimer's probably do not. But that 15%, it doesn't matter how good the physician is. There's no way to distinguish these. The fault lies with medical researchers like myself now, who have not yet come up with really good diagnostic tests that physicians can use.
Right, because the only place that you can diagnose it for sure is on autopsy.
Is on autopsy, right. Now, there are some tests that are in the works, and there's a lot of a mention of these in the press. There are some tests that look at amyloid, for example, in the cerebrospinal fluid. There are some tests that can look at the ApoE gene that we discussed that may be involved as a hereditary risk factor. There are some other tests that have been developed looking at skin cells and the potassium channels in skin cells that seem to be altered in Alzheimer's patients. But none of these tests are yet at a point where they have been proven to be reliable enough to really be beneficial in making the diagnosis of Alzheimer's disease. Hopefully in 2 or 3 more years there'll be enough data to where we can add one of these tests or 2 of these tests or maybe more to the arsenal that the physician has at his disposal to make this diagnosis.
We have about 30 seconds left. Is Alzheimer's the type of situation where somebody comes down with a diagnosis of it? Would it be good to go for a second opinion?
I think that sometimes that's good, but I don't think it's generally required. If the person has a good workup, good neurologic workup with blood work and neuropsychometric testing and perhaps a brain scan, in general, it probably is not going to have a very high yield or pay very much to have a second opinion. That's my personal opinion.
Okay, well, we're out of time, Dr. Fry, and I thank you so very much for coming tonight and for talking to us about Alzheimer's disease. And I thank all of you out there for watching. And until I see you again, you stay safe and you stay healthy, and good night.